You're listening to the Physio Matters Podcast in association with Choose Health, and this is session 20. Welcome back to the Physio Matters Podcast with me, Jack Chew, for a landmark session 20. Massive thanks as ever to the podcast team, Rob Tyre, Jack March, Rich Barnes, Charlotte Rattenbury and the returning Danny Smart, all of which have episodes in production. I hope that a lot of you have noticed there's been an influx of new podcast streams from therapists around the globe, and for this reason, as well as accounting for a couple of more niche episodes, we've averaged 22,500 full listens through 2015, which is down from the 27,000 that we often brag about. And so just as we would tell you of increases, there's our latest figures from Mr. Statistics, Paul Bibby, just to be fair. Every 6 months we sample our listeners for feedback. However, this time we've created a more thorough survey online for as many of you as possible to let us know your thoughts on what we're producing. We hope it will circulate around departments and institutions to include non-listeners as well, so please get it shared by finding the link on social media, and we'll be sharing that as much as we can. Today's session 20 is an interview with Jo Gibson, who I personally have the utmost respect for in terms of her professional manner, balanced reasoning, and of course her expertise in a clinical area that I often struggle with, which is shoulder instability. Jo kindly spared some of her time to chat around wobbly shoulders at her home in West Kirby, Merseyside, and she introduces herself much better than I can, so let's just get to it. Listen up after the interview for a brilliant discount code for a new course run by an ex-Physio Matters podcast guest, Heather Watson, who's running an innovative new course coming soon. So thanks for having me here today, Jo, especially because you're not so well, which is, I'm sorry to hear, but yeah, try not to cough too loudly down the microphones, and we'll get chatting. Would you like to introduce yourself first and foremost?
Yeah, absolutely. I'm Jo Gibson, and I work as a clinical physio specialist at the Liverpool Upper Limb Unit. I'm a partner in private practice, quite local to here actually, and then I do quite a lot of lecturing as well. But I've been at the Liverpool Upper Limb Unit for a very long time. We set that up with a guy called Simon Frostick in 1995, and really have been there with my team ever since, and it's grown to incorporate 5 shoulder surgeons and a team of 12 physios, so I'm very lucky.
95 you said, so
yeah,
what led to that?
That's a really, really good question. And when I was sort of contemplating this, essentially when I was a junior, I ended up in Nottingham. I had a place at medical school, flunked my A-levels, had my life rebellion at exactly the wrong time, always wanted to get into sports. Got a job in Nottingham, and on my orthopaedic rotation, our treat at the end of the rotation was to follow a guy called Angus Wallace, who's professor of orthopaedics there and very well known in the shoulder world. And he was just so passionate about what he did. And I remember following this guy around in this ward round, and he developed some new prosthesis for the shoulder. And it was the first time I'd met somebody that was so completely enthused by what they did. And it really left its mark. Hated treating shoulders, never understood why ultrasound and a bit of postural correction didn't do it. Went to Liverpool, did the usual rotations as a band 6. Went to Liverpool mainly because of my husband, rather than any career intentions. But then wanted to get out, started setting the private practice up at the very time that Simon Frostick, who'd worked as Angus's fellow, came to Nottingham. And at the same time, I was doing my MACP weekends and had done a muscle imbalance unit. And I remember sitting there thinking, yeah, this probably explains why I haven't really had a huge amount of success in the past, and realised there's this whole world of stuff I didn't understand. Went to meet Simon, said about meeting Angus Wallace, and he was like, well, I need somebody in my clinic. And then basically I wangled my way into it shamelessly because it seemed like a great opportunity and something new and interesting. Right. And he was pretty tough on me for the first 2 years, and that literally would just expose me in front of the entire team and get me to really put what I thought on the line. And I've never read so much in my life. But after the first couple of years, he just basically, wherever he went, he insisted that I went, because he was absolutely adamant that surgery was a very small part of the story and that the rehab was what mattered. And then as part of that, he introduced me to various world experts, and I just applied for fellowships and just made sure I went to see all the people that at that time were considered names in the shoulder world. So I was incredibly lucky, and I sort of spent some time with Ben Kibler in Kentucky. I spent some time in New York with some of the guys there. Met Lynn Watson in Australia, but also a lot of the UK experts at the time. So Andrew Jaggy's predecessor at Stanmore, Karen Sibelia, and then there was a couple of girls at Nottingham, Dorcas Damrell and Anne Mackey. And they were just so generous of their knowledge and time. But then there comes a point where you've sort of got everything you can from everybody else and done every course that's going, and actually you start to have some responsibility and put it together in something that makes sense for you. So Simon was massively supportive, and we were soon joined by another consultant. But essentially, it was free rein and there weren't there weren't any shoulder specialists at the time. So I was very lucky that I had a voice, and I was so keen to take that responsibility seriously and really promote physio and do the best I could. But I had just a tremendous luxury of lots of patients with the same pathology to play with, and it basically came down to me that I had to make those decisions because we were running out of places to send them.
And so you were a glorified groupie for many years. That then,
Absolutely.
Then I'm sure you get groupied on though. But you I'm sure mentor through people through the ranks.
Yeah, well, yeah, it's been really exciting. I mean, we have a combination of rotational and static staff, but actually in the about 4 years ago now. Really because of the vision of some of the surgeons I work with, but also something we've been pushing for a long time. We've actually got an industry-funded physiotherapy fellowship where somebody spends 3 years with me, and the bad side is they have to be mentored by me, but the good side is they get funded to do their masters, and they also have some research time within their post. So anything I've done research-wise in my life has been in my own time, but I was really keen that somebody had the opportunity to do that as part of their clinical practice. And so now they basically come and work with us for 3 years, and then we're on our second one now. So that's been really exciting.
Amazing. No, that's lovely. And getting that balance is something we always try and talk about with our guests, is that usually most guests have had this research background or an interest in research and bringing that to the fore. So that's clearly an important part of what you feel is contemporary practice.
Absolutely. And I guess I feel I've played at it. And I mean, some of, my great influences, obviously like Jeremy Lewis, who has just been such an ambassador in terms of what he's done research-wise. But I've also been very keen to make clinicians realise that whether it's an audit or an observational study, it still has validity. And I think we need to not be quite so scared, because some of those experiential studies, as long as they're done in a sound way, actually have a lot to offer. But I mean, my own interest has been very much, I'm not great at giving up with somebody if I don't understand why they're not getting better. If I know that I'm not the right person, that's fine. So a lot of what I've done research-wise has been driven by trying to find solutions for people where we were told there weren't any, and shamelessly just nicking ideas from other specialties or, other areas of the body, I guess. And it's been a great luxury to have enough patients to be able to measure that in a fairly meaningful way.
Yeah, I mean, it's often the thing that drives many clinicians is that bit between your teeth of why is this not working? And it's in such a young profession, that's why it's such an exciting time. But and you mentioned Jeremy Lewis. I've been very fortunate enough to interview Jeremy and broadcast an interview with him, equally Dr. Ian Horsley, regarding the shoulder on our Physio Matters stream. So we wanted to discuss shoulder instability more specifically, and I know I'm going to start with a tricky one and say, how would you clinically define shoulder instability?
I think in its simplest term, it really just relates to having symptomatic, abnormal translation of the shoulder joint. And that can manifest as just a simple sense of something not moving correctly or displacement or frank dislocation. But the reality is it can be a combination of structural and non-structural causes. And so it's a huge spectrum.
And so symptomatic in that sense, are you meaning it has to be painful, or are you meaning that symptomatic being how I suspect you're meaning, which is that dislocation or regular subluxation would be a symptom of this?
Absolutely. So more it's common that if we get there is some element of instability, though obviously when we talk about the subgroups we can sort of elucidate that a little bit further. But the reality is patients will present with either pain or instability, but there is usually some description that it doesn't feel right, or it feels vulnerable in certain positions, or that certain positions manifest their symptoms, and it's different from your sort of subacromial pain syndrome type patients.
Okay. Is it a condition that's been easy to define over the years? Has there been a lot of discuss around why, how it's defined, or what should be grouped into what? Is that something that's been a problem?
I think there's been massive discussion, and there are endless classification systems, and I think it's absolutely symbolic that there is still a lack of consensus on an international basis of one particular classification system. I think the Stanmore group have done a huge amount to sort of advance our understanding and do a better job for patients, so that those that were probably previously written off as mad, bad and sad, we've got a better understanding and actually some more treatment options. But in terms of... there are so many, but the reality is we in our unit tend to use the Stanmore triangle because that's in the UK what seems to be the benchmark. But if you start reading the literature, the problem is nobody can agree on the sort of diagnostic criteria. If they elucidate diagnostic criteria, then actually there's very little validity or reliability for those. And depending how you interpret them will massively influence the sort of incidence of a specific pathology or subgroup. So it's very difficult, because then if you try and look at the literature to compare treatments, you can't, because you can't agree how to classify them in the first place.
And if it's one of those things, if you extrapolate it too thinly in the subgroupings, then of course it's going to make it too small a sample, and therefore a tricky one. I mean, the Stanmore triangle you mentioned already, and it has proven very popular and quite rightly so. But if you were to polarise the classifications outlined in that triangle, what are the typical clinical presentations that they represent?
So Ian Bailey obviously was sort of the instigator of this originally, and Andrew and Simon and the rest of the team have really taken this on and developed it. And really it developed from Matson's original classification of Tubbs and Ambry, which was very much the traumatic unidirectional instability that typically had a clear history of trauma. They ended up with a labral tear and needed surgery. So your traumatic unidirectional Bankart surgery is your Tubbs. In terms of the Ambry, which was at the other end of the spectrum, was your atraumatic multidirectional, who basically often had bilateral laxity, but rehabilitation would be your treatment of choice, and only if that failed, an inferior capsular shift. So really what the Stanmore team wanted to do is then acknowledge this further group of patients that had a aberrant muscle patterning. So in terms of going through the different polar groups, the polar type 1 really reflects that traumatic group. So a typical presentation would be your rugby or football player that falls over on the pitch on a Saturday, arm in abduction, external rotation, gets an anterior dislocation, has to go to casualty, have it relocated, and then we can have the whole dilemma about whether they should have surgery or not.
And when we shall.
Oh, good. I feared we might. And so, but also that group, the key thing with that polar type 1 group is there is some element of trauma in their history that is consistent then with their clinical findings and where they're likely to have elicited some sort of structural damage. So it will encompass your slap lesions, your posterior dislocators, which, we're all brought up in college that the most common reason for your posterior dislocation is electric shocks and epileptic fits, but actually the reality is the most common mechanism of fall onto an outstretched internally rotated arm. So that history of trauma is absolutely paramount, and something I get quite boring about when I read all this literature about how you can't diagnose anything. The reality is 70% of our decision making is from that subjective history, and in the shoulder with instability, that history is just paramount. So in your type 2, your polar type 2 group, your atraumatic instabilities, and atraumatic is this sort of word that causes a lot of controversy, because in this group you've got an inherent capsular dysfunction. So essentially the glenohumeral capsule, we know from Scott Rodeo's work, actually doesn't have enough of the good collagen to give it structure and has too much elastin. So essentially there's too much capsular volume, which has various knock-on effects in terms of muscle recruitment and proprioception. But the reality is the problem with that group is because we know about these proprioceptive and muscle deficits, potentially it takes far less trauma to cause a structural element. So this atraumatic is a little bit open to interpretation, but really within that Stanmore triangle, the key thing is they don't tell you, I fell over.
It's a less traumatic.
Yeah, it's not a high energy sort of impact. So there's no definite, this is what I did that made it come out. It's a much more sort of nebulous build-up. And so again, in that polar group, the key thing is they don't have any muscle patterning. So that really reflects that Ambry group. And in terms of how they present, again, it's very difficult because, again, you've got a spectrum. You've got your sort of lax Lucy, I guess, who might have a background of hypermobility. But the key thing is the shoulder generally falls out. So I like to think of the tubs as the torn out because there's been a history, the type 2s as the fall out, and generally they can reproduce a position where it falls out because basically the cuff doesn't do its job properly, or for whatever other control reasons. But this group also encompasses that sporting population who may have an acquired laxity, but also the ones who, again, inherently the cuff doesn't do its job properly and we have this uncontrolled translation. And they often will manifest slightly differently in that often pain is more of an issue, and often they'll present with biceps type symptoms because that direction of lack of control is anterior and basically the humeral head just butts into that biceps. So interestingly, the treatment approach isn't necessarily terribly different, and the thing that links all of it is this capsular dysfunction and lack of an actual traumatic onset.
We're going to try, if we can, because the lines do get blurred, and I've just asked you to describe polar types, but we will try and fill in the gaps because, of course, you've got your. And I was going to say, I'm just going to drag you into the third one because we talk of grey areas between those two, which are almost fairly clear to see. But then there's this third one that really gets complicated almost. Well, it is certainly seen as being the scarier of the three, I would dare say, in clinical practice. Firstly, would you say is it fair to consider that the scariest? Is it the most difficult?
I think that's a great question. And certainly it's the thing that consumes most of my life in terms of trying to find solutions. But actually, I had to talk about this recently to a consultant who said I always confused him and could I finally do a lecture that he understood. And when I looked at it and actually looked at the evidence, the reality is even if you split them into these polar groups, so what we're talking about now is that polar type 3, where essentially there's no structural injury, there's no capsular dysfunction, and basically muscles pull the joint out. So I like to think of them as the pulled out. So essentially the cuff's suppressed and your pecs, your lats or your deltoid or a combination result in that dislocation or subluxation. There is no doubt a subgroup that are complicated, and developments in fMRI and some of the, magnetic cranial stimulation, some of these tools have given us a real insight that there is a sensory-driven process in some of these patients. However, the basic principles are very similar in that they have proprioceptive deficits, their cuff doesn't switch on well enough and do its job through range, and there may well be contributing factors elsewhere in the kinetic chain, but the fundamental treatment principles are very similar. The challenge, I think, with this group is, one, they've often been looked at and people have gone, oh my Lord, I've never seen anything like this before, which clearly from a patient's fear and understanding point of view starts to really set off these sort of fear avoidance and emotive pathways. But also, I think there are other factors which may relate to changes in the brain or may relate to neurodevelopmental factors that just mean our normal physio approaches are destined to fail, and it just requires us to reevaluate where we start.
Because I mean, you were nice to call it a good question, but I've just heard it back and realised just how flawed that question is, really. Because the only reason it's scary or considered the most difficult is because it doesn't sit well with a very mechanical framework. We've got very easy things that we can attribute a diagnostic to, and therefore, just because there's this type 3 that's less understood, that's probably the only reason it's scary. Is that probably fairer to say?
In some ways, I think it is, but also I think what you have to remember is the whole premise of the triangle in the beginning was because there were this group of patients that had been very much labelled as being voluntary dislocators, and the inference being that they had a psychological component. So the message initially in the initial sort of papers from Alex Malone and Ian Bailey himself and the rest of the team was very much the problem is if you operate on these people, they're destined to fail, because if you operate on them just once and they have an anterior direction of instability, in this muscle patterning group, you reduce the chance of rehab getting them better by up to 5 times, which is phenomenal. And scarily, if you follow them up over time, there is a massive prevalence of developing degenerative changes, because you've now created false stability in a joint with no structural pathology. So that now this aberrant muscle patterning is happening on a background of stiffness. So it's not hard to work out that will result in joint loading. So I think in trying to make us more aware of this patterning group, there was almost a fear factor needed to happen to at least say to surgeons, please don't operate on these patients because you really are stuffing them up. But also to make us realise that they were maybe a little bit different in terms of we needed to look for other treatment strategies. So I think we don't need to be as scared, and I certainly don't think we need to think we can't treat them, and the basic principles still apply. But I think what's exciting is the developments in the pain sciences, and certainly what fMRI is giving us is an insight into perhaps better treatment options for these patients.
I guess you're saying it's only exciting if we actually get the diagnostics and patient selection right.
My key issue always is the history in terms of ascertaining the onset, because I think that to me is massively useful. And then really within those type 2-3 groups, I guess, does that I'm more interested then in what the driver is. So Kathy Barrett did a lovely article in the Shoulder and Elbow Journal recently that really looked at those, those sort of that breakdown of drivers within those 2 groups, and some of the things we've alluded to, like the neurodevelopmental stuff, like the centralisation of pain, the cortical changes, the psychological aspects, all of which are well demonstrated in other pathologies. So I guess I have the triangle and the time in my mind, but I really want to understand the patient story and how that's impacted the structure, or whether there's things about the language they're using that point me to psychological or psychosocial drivers. If there's something about the story, there's an overuse or an overload element that's just, defeated the abilities of that joint. So for me, listening and getting that story really guides my considerations for what I then pursue. Brilliant.
No, that's great, and that's always sort of a common theme we'd say on these podcasts and others, is that key not just the mechanism of injury, but everything that comes around the subjective and how it's delivered and how it's elicited. So it's great to hear that that's as with other body parts as well.
Absolutely. There's just one other thing that probably is worth saying just to people that are seeing these patients and not quite sure where they fit, because the patterning group are very common story that they'll tell you, particularly when they're coming to a tertiary referral unit because they've been through the mill so many times, is that these people go to casualty despite a lack of trauma because the shoulder's dislocated for whatever reason. And a really good marker is they'll have been given Entonox or been taken to theatre and had the shoulder relocated, but as soon as they wake up or very quickly after, the shoulder comes back out again. And that's so rare in a truly structural polar type 1 group. So that's one of those little history cues that can be very useful in ascertaining you've got a patterning patient.
Brilliant. And I'm glad you mentioned that. Any other little snippets of subjective information that would be different that people might not even think to ask, or would you give the listeners any tips for when they're scratching their head and it's not quite sitting well with something they might have even seen before? Are there any other little gems?
I think as soon as you have somebody who's reporting symptoms that are consistent with instability or are within that age group where instability is your likely diagnosis, if you don't have a clear history of trauma, is one, to be really sure you haven't, because the number of times I get asked to review patients and the poor junior sits there having thought they'd done a really good subjective, and I say, have you ever fallen or injured? Oh yes, I remembered I was in a car accident or whatever. So being really clear that there is nothing, because often what patients perceive, they may think they've got to be the footballer who fell over and actually dislocated, as opposed to they fell over in the road or were in a car accident. But having ruled that out, really the next things in my mind are clearly how it started. So, there are common spikes, if you like, developmentally that Simon Lambert showed very nicely in some of his work, that correlate very nicely with developmental spikes. So it's often useful to ask if they have any issues with dyslexia, when they started to walk, all those sorts of things. And certainly with the hypermobility group that are falling out of joint, you often will find some mild learning difficulties or some evidence of developmental delay. If you don't find that, then they're usually super bright and very visually compensated. So actually, when you start to look at their balance and things, you start to find that they've just cheated very well. And actually, there's a guy called Wayne Org who actually looked at this hypermobile group with multidirectional instability, so the polar type 2, and showed that there was definitely a subgroup where some of their more innate reflexes remain very dominant. So once they get to a problem, they can't then re-access that selective movement. So asking that background history can be very useful. It's very disappointing when they say no and everything's normal, because then you've got to find something else, but that can be helpful. The other thing that's also useful is people who've had some sort of history of trauma unrelated to their shoulders, so whiplash or any sort of neck or spinal injury, because again, there seems to be a correlation with some of the oculomotor and proprioceptive issues around the cervical spine that can have a big impact on the shoulder, again, in that sort of young female hypermobile group. And then I guess in terms of the muscle patterning group, the sort of questions that I'm interested in knowing is a lot about their pain, because as soon as you start to get descriptors that are consistent with allodynia and hyperalgesia and some of the things that we relate to centralized pain, I'll then just pursue it a little bit further and ask them, does it feel like your arm? Because what we found is there's quite a lot of parallels with the very painful group that sort of don't even want you to touch the arm, and some of the findings in CRPS. So that can be very useful, because again, that will send you down a line of assessment where you might want to look at things like 2-point discrimination and left-right judgment. So if you like, it's really a bit of detective work. Is there anything in that history that suggests a structural problem? And again, as I say, you just have to be a little bit careful in that lax group. For example, I had a girl that went on a zip wire, and she basically, her knee got trapped on something as she landed. Now, that hadn't been considered significant trauma, but her whole body kept going while her arm stayed still, and she ended up having significant structural pathology. So really just unraveling that injury history. But then in the absence of that, what are the other things? And I suppose the last consideration, sorry, Jack, I'm going on forever. But
keep going.
But the last consideration is also that sporting group, because I'm very fortunate in that I get to see elite athletes, but not so fortunate because generally only when their club physios or their personal physios can't get them better, which, I'm not arrogant enough to think I'm going to do anything different, but it's unraveling what is it about that system that's stopping it all come together when they've clearly had good rehab. And actually in those patients, what's interesting, often there's a lower quadrant injury that's actually been the thing that's tipped the system over the edge. So the shoulders had to compensate, the cuff hasn't coped, and then they become pathological. Mm-hmm. So I guess I've given you lots of different things there, but what would send me in that direction, whether I had somebody with a clear history of injury in that polar type 1 group, which is relatively simple, it's just then what are the contributing factors that I might have to consider in my rehab, and then the type 2 and 3, have I got somebody moving more into that neurodevelopmental group or somebody more into that pain group? And then that's just very helpful in then prioritising what I need to look at assessment-wise.
You mentioned some parallels with regards to CRPS. Is there a degree of sensory neglect that goes on with that doesn't necessarily correlate with the chronicity of the symptoms? So you've got someone who's being very protective and therefore almost neglecting that limb, even if they've not had it for a long period of time.
There's so many answers to that question in terms of our increase, and this is what's so exciting about the stuff that's coming out with fMRI and some of the sort of brain imaging modalities. There's several answers to that. One, there is absolutely no doubt that there is a group of patients, whether they're traumatic or atraumatic, that the reaction to that original onset and their own belief system will very quickly push their processing of movement into their emotive pathways, which is very much like the back pain patients. There is a subgroup of patients within what we call the patterning polar type 3 group that actually have correlates with the CRPS in terms of, if you measure their 2-point discrimination, they have massive dysfunction in terms of their spatial awareness. So I think there are some patients that have almost a kinesophosia, can't say the word.
Kinesiophobia.
Thank you very much for that, Jack.
That's all I've got is words.
So they have that. And then you have a group that I think have a true sensory neglect, very much as the CRPS patients do, which is actually driven by changes in the central cortex.
Wow. And as you quite rightly almost opened with, is that if you were to try to extrapolate every single one of these subcategories, we're in such low numbers that we are naive to suggest that these should all be RCT-driven guidance. It's just not realistic.
And I think that's the massive challenge. And I think that's why we've done lots of case series, of small groups of sort of 20, 25 patients. But the reality is, if you look at the general population, you might see one of two of these in a general hospital department, and certainly accounts for less than 5% of all instability. If you work in a tertiary referral unit, it's probably 45% of what you see, because everybody's sending them because they haven't got better. Yeah. You're absolutely right. And that is the challenge, because trying to reduce the case definition to a level where you can have some consistency for what a randomized controlled trial would demand is just not feasible, because there are so many variables.
And us understanding the context of the clients we see, so the patients that we see, so you don't feel like, oh my God, it's everywhere, and we don't get complacent in thinking it's nowhere. It's important for us to recognise and be talking to each other, I guess.
Absolutely. And I think the key message as well, really, I guess the older I get and the longer I do this, I just realise that I make things simpler and simpler the longer I go on. And the reality is, as I said, that most patients, 80-85% of your instability will get better sticking to basic principles. But in this small subgroup, it's really quite empowering to have things like 2-point discrimination and left-right judgment and other tools that we can use to assess. Because one, they'll either identify a way forward, or if they're normal, you're left with the fact that there are a very, very small, subgroup of patients that truly have some sort of secondary gain or psychological issue that's driving their problem.
It's something that usually can be elicited fairly early in a process, and is best done early in a process.
Absolutely.
Would say.
Yeah, well, interestingly, that was one of, when I did my master's, my dissertation was all about the biopsychosocial model and how it's been a bit lost in translation over the years. But central to that for me was, there was always this elephant in the room with certain patients where you suspected there was a drive, and I was always a bit scared to ask. And I think doing a communication module and just realising that actually if I ask the question and they answer it, it just ascertains I'm not the right person for them, and actually perhaps a psychologist or somebody else is. So that's been massively useful.
We've said about these grey areas in the Stanmore triangle in any categorisation system, but we will now come up with a little makeshift case study where it drags all three of those in, and something that inevitably I'm sure you see on a regular basis. But we've got a traumatic dislocation of someone who is a polar type 2, who has hypermobility, for example, who then develops adverse muscle patterning. So we're literally with a type 2, then 1, then 3. I'm interested in how the management of that person might look and the reasoning process behind that, but I'm also intrigued as to, we can't all be doing very well with those patients, so they wouldn't land on your doorstep. So where is it going wrong? Might there be reasons as to why it is, and is it on the change?
What I would say is I think the complexity of what we're seeing now is much greater, because actually the standard of physio is very high in shoulders. I think there's been a real sea change, and that actually generally people get a lot more of these patients better than they did before. But what you've described is absolutely typical of what ends up on the doorstep. And the problem is, if that person with the background of laxity has that traumatic dislocation, two things can happen. Either they don't have surgery that they need because they're lax and somebody believes that that's going to be negative. And actually, you know, with what Andrew's group are doing with their research and some of the sort of more recent studies, it would suggest there is a case for surgery despite the laxity. The risk is they're more likely to develop muscle patterning. The problem, if you've got the person with laxity who's got a dislocation who now has patterning, is that patterning relating to the structural injury? Is it relating to the fact that they're lax and you've just completely set that local system over the edge so that it no longer switches on? And what happens next will determine your chances of getting them better. So for me, I guess coming to us, it would depend where they were patterning, because if somebody's patterning as a result of structural pathology, those muscles should only pattern where you expose the structural pathology, so it should be very positional. If they're patterning through range, then clearly that's less likely to relate to that structural element. The common thing we see is they'll have had surgery, they'll have addressed the structural pathology, but then they'll also have tightened up the capsule because it's lax. They didn't need to do that, because then you've got a background of stiffness for that patterning. The pain gets worse, that inhibits the cuff, and the whole muscle pattern sequelae gets better established. That immediately makes it harder for me to get them better. And so really it's having a surgeon that when he looks in that shoulder understands or considers the whole picture. And as I say, we're very lucky with the surgeons in the UK generally, but clearly if you're not a specialist and you have somebody who's had traumatic dislocation and you see capsular laxity, why would you not address it? The reality is, if it's not pathological and it isn't torn, you should leave it alone, because the reality is immediately it will make rehab harder.
Is that something that's consistently professed amongst orthopaedics as well as it is amongst physiotherapy? Is there that consistency now?
I think the consistency is better because of the Stanmore triangle and because the job they've done trying to educate surgeons. I think that the difficulty is it's almost back to pendulum. It's almost swung too far the other way, and it's back to that history again, because the reality is if somebody with laxity has a traumatic injury, arguably the sort of proprioceptive feed forward and feedback loops between the capsule, the ligament and the cuff are inherently flawed, and we know that from the research. They already have potentially proprioceptive and muscle timing problems. This is without considering any sort of central element. So basically, they'll find it incredibly difficult to access that local system. You add surgery on top of it, you make the joint stiffer, you potentially drive that muscle patterning. So you see how very easily just one operation can really stuff things up. The problem is they have that one operation, things don't go well because they get pain. They either then get stiff or they redislocate. So then the rehab chance of getting them better gets less and less and less. Surgeon feels obliged to do more and more, and that's where things can really go wrong. So I think it's back to, I know it's very sort of, you know, it's a trendy thing at the moment in team working and the patient at the centre of that decision making. But that's why hearing and listening to that whole story is very important. Because for me, if that muscle patterning was positional, surgery is a good option for that patient. If it's not, then I need to unravel those other drivers. But there's no reason that potentially that patient won't need surgery. It's just optimising them to get the best results.
And working out the right timing for any bit of
Absolutely.
that process. Now, it's not me for a second wanting to be disparaging about our orthopaedic colleagues, but it is what you've just described is quite distant from traditional orthopaedic reasoning, in which something might be fixed, being broken and need fixing, for example. And so Bess was recent, and you've been it's been part of something that you've been involved in for quite some time. Do you feel the tide is I'm not going to start say turning, I'm sure it turned many years ago, but in terms of it, is that something that's wrong of me to say in current day? Is that reasoning still inherent?
I think, again, it comes back to what we've alluded to several times is beliefs, because the reality is, me as a physio, my beliefs will have a huge impact on whether a patient gets better or not in terms of my interpretation of their pathology. And it's exactly the same for surgeons. They'll they have their belief, their influences, whoever's trained them, and depending on what their experience of instability is, I would have to say, for very much the same reason that the complexity of what we're seeing is greater, is because generally the standard of surgical intervention and what people are doing is better. And I have to say, a lot of that is down to this awareness of the Stanmore triangle. So sometimes it's almost better not to do anything if you're not sure, and refer somewhere where they'll have that reasoned process. And I think those pathways are better established. And I think Bessin itself has been a vehicle to educate those surgeons. So I think it has turned, and I think there is a greater awareness. But sadly, I still see patients that have had surgery where arguably they shouldn't. But also, as I sort of alluded to before, the pendulum's almost swung so far that it's back to what you said about physios being scared. Surgeons are a bit like, well, I better not operate because they're lax and they've got patterning. So I think I think the sort of study that Andrew and Karen Ginn are doing is going to maybe throw some light on helping us identify the patients where surgery is a good option. But, we've talked about lots of different approaches to treatment, and whether you do local cuff work or all the things I've talked about, the reality is lots of things work, and a lot of it seems to be coming back to proprioception and the brain and getting that cuff to do its job properly. I want to know, is there something the surgeon can do to help me do that better? Or fundamentally, is there something structural that will stop me being able to achieve that? I do think surgeons are doing it better, but as ever, there's room for improvement. And I think that's why we have to keep talking. And
not that I'd want to, but I'm not in a position to disagree with the fact that the surgeons are doing better surgery. But might it be, I don't know, are you thinking out of politeness or something that might be the case? Because if you're seeing increasingly complex set of circumstances around a person or a patient that might have had, part of that is contributed to by poor surgical choice. Are you meaning that the procedures, when they're chosen right, are done well? Or are you suggesting that actually the choosing of the surgery is equally improving?
That is a really interesting question. I think what I mean is that I think that the clinical reasoning is better because people are more enlightened about what the role of surgery is. I think I'd go back to what I said before, is the problem is the more that we know, the more we realise we don't know. And so that patient identification for surgery is quite difficult. When I say we're seeing more complex patients, it's generally the ones that have had lots of rehab but haven't had lots of surgical intervention. Whereas when I looked to sort of 5 years ago, there was a lot more surgical, patients would come having had 8-9 operations, all of which had failed, but people were still operating. Now it's that they've seen 8 or 9 physiotherapists and the surgeon won't operate, so now they've come to us. So there is a change.
I see.
And a sort of increased reticence to operate because of what the Stanmore triangle has done, which I think is healthy, but I think we're at a real changing time again, because we're almost having to reevaluate and say, you know what, we're very anti-surgery for everything at the moment, but actually there are some patients where, you know what, it does have a role to play.
There's a first for the podcast, certainly. Rehab centricity going on in shoulder instability. No, I can understand that, especially if, as we've discussed, there is that complacency to be very specific with what they might need and strengthen this, for example. It's much more complex than that, which you've been able to elaborate really nicely, so thank you very much for that. But as with the vast majority of clinical areas, there are several pendular swings with regards to how patients with shoulder instability should be assessed and treated, namely the very particular art of recognising and influencing the conscious snugging and centering of the humeral head on the glenoid versus the opposite idea that just brute strength is the only means to compensate for instability. So I've just tried to describe two ends of a spectrum. I hope I'm sat in the right place to think that both of those are probably a bit daft. So where do you say on that spectrum, if hopefully around the middle? And what does the evidence tell us in that sense?
So I think the whole idea of snugging the humeral head in the glenoid came a lot from Guy David's work, who worked with Mary Margery, and showed very clearly that there was this sort of pre-setting phase of the rotator cuff just before movement. So all the cuff, apart from subscat, which seems to be a bit deck chair-like, co-contracts, and it was always considered that this was to snug the humeral head in the big part of the glenoid. And the reality is, it definitely presets, but in terms of what it does mechanically, there's a massive variation, and that humeral head probably moves far more than we've ever given it credit for. So there was a lot of obsession with this co-contraction. However, I think what we mustn't underestimate is, even in Prof. Ginn's work, again, there is definitely this presetting phase, but arguably it's more to do with proprioception and engaging that system ready for action than it is actually about biomechanical placement of the humeral head.
We searched for normal though, didn't we, a little with regards to that. I've really tried to troll myself through some historical research there, and it just, understandably, the assumption was made that this was the normal mechanism of the shoulder, but without recognising the variation. Granted, it's moved on massively since then.
I think so, but I think also based on the fact that at the time there was some fluoroscopy studies and some very sort of new dynamic fMRI studies that were showing that the difference between patients with pain and instability and those without was that the humeral head moved more. So it sort of fitted quite nicely with the model that actually, and in that I would sort of tentatively agree that basically if the system doesn't start right, then arguably it's not going to activate right through range. So there certainly is. The other thing that's clear is that there's no doubt in pathology that presetting function is lost.
And it's one of the, I would dare say, few things in MSK these days where the word dysfunction is pretty appropriate. You know, there's certain things, there is the fact that it shouldn't be subluxing and dislocating on a regular basis, regardless of why, is certainly a dysfunction. It can't be. That's where it can, on that spectrum, be considered
I think we can be allowed to use it.
I think so. They're good.
Yeah.
Because it's all over my notes.
But I think for me the challenge is, and you know, thinking about, and then you sort of asked me about strength, is that again, if you look at the historical literature, and certainly America, JP Warner and people like that just led the world in terms of looking at ratios, and they were dysfunctional, and the posterior cuff was weak, and then you'd pick up another study and it was the anterior cuff, and then the reality was, well, what should the ratio be anyway? And you know, there's no doubt that you need a cuff that can support the weight of the arm and is strong enough to do what the patient needs to do. But in terms of where I sit on the spectrum, apologies to Adam, but I'm not the Arnie Schwarzenegger of the physio world, because to me, a lot of the patients I see have done a lot of good strengthening work, and yet it's not working for them. And so for me, it's the presetting is important because the system needs to switch on right. But actually, the way I look at it is, I think the evidence is clear that there is a timing issue, and that is the consistent thing in the literature. And there is a proprioceptive deficit, irrespective of the type of, you know, instability. So with the current trend for sort of improvement tests, that's where the evidence is very helpful, because actually, if I give them some proprioception and facilitate the bit of the cuff that should be working, so we know from Prof. Ginn's work, you know, through elevation, my posterior cuff should work harder to counteract the anterior prime movers. Well, if I basically give a little bit of compression and then facilitate that posterior cuff, does it stop it dislocating? And if it does, well, I don't know that I've normalised their muscle recruitment, but based on the evidence, it would be a reasonable summation. I've changed something about how that muscle system is working. But actually, what am I interested in? It's stopped them dislocating, therefore it's a good place to start with exercise prescription.
Right, and we're getting to the realms of symptom modification. Now, I would, if just to drag that clinically and say, I know myself, and I know certainly from colleagues of mine, especially those that knew I was coming here, a lot of people fearful to even dabble with those tests. What you've just described is something that people sometimes will even have been encouraged to avoid by their senior clinicians when they came through. I spoke to someone, incredible physio, 10 years qualified, that suggested that it was many years that they wouldn't externally rotate an unstable shoulder out of absolute fear of spontaneous dislocation under any parameters. Now, a lot of people aren't even doing those tests, and it's what you've just described as being helpful diagnostics. Is that still around as much as I'm sort of suggesting it is?
Well, but I think that comes back to what we were saying about the importance of history and knowing what their provoking positions are, because there is no doubt in the really severe dislocators who don't even want to lift their arm up. The reality is, you know, if you just get them to bend their elbow, you'll be able to palpate their lats and pecs activating. So arguably, you can use the same premise in terms of facilitation by giving some compression and getting them to repeat the elbow flexion and seeing if that switches the muscle off. Because if it does, again, you've immediately got somewhere to start with your rehabilitation. So I guess the ingredients of what I'm saying, I expect it to change, and I am watchful and considerate of the patient experience. I'm certainly not going to ignore instability, but I think the way we have to look at it is if we engage that system more effectively, we should be improving that instability. So the only time we need to be fearful is if we're taking somebody into abduction external rotation that's got a proven Bankart lesion, where absolutely we've got the potential to dislocate them. But actually, I think with, sensitive handling and considering what it is you're trying to change, and obviously that's on the background of making the postural cues, etc. Actually, it's phenomenal how effectively you can change somebody's movement quickly.
Yeah, brilliant. And that's the key thing, is that it's instantaneous, isn't it? And that it can be quite tangible, is that difference. Now, to be awkward, because it's my job, but if we're saying that to overtly just think that this is a strength deficit is far too one-sided, it does, what you've just described leaves it open to going fairly far the other way, in that if someone says flexing their elbow and we're then assessing, sometimes it's overtly there's some gripping going on there from muscles that you wouldn't ideally want gripping. It does leave it open to being this subtle art of detection, in which you are, through palpation or through seeing maybe what you might want to see. Not for a minute suggesting you would do that, but it does then leave this grey area of clinical expertise, in which this is already a subgroup of people that we don't see a lot of in a normal primary care sort of setting, or if we do, they're the ones that, as we've said, scare us. So does that open a can of worms, is kind of what I'm meaning there?
No, well, again, I think, that makes me reflect on what I'm saying, but I absolutely not, because I think, one, the facilitation that I'm describing, I would, with your fairly straightforward type 2s and 3s, I would expect it to change, because to me that's optimizing muscle recruitment. In terms of what you're saying and in terms of palpation, I have absolutely no problem with that, because there is no doubt, I know when I'm teaching people, there's this sort of element of, well, that's great, Jo, you can see it, but I can't. And then I have to think, well, am I actually really seeing it? It goes back to what we said before. If I've got a lot of pain, the first thing I'm going to assess, particularly if it's that allodynic group, is what I said about the 2-point discrimination, the left-right judgment. If those things are positive, I'm not going to try and change how they move, because the reality is I need to get the brain right before I can get the muscles right. With that type 2 falling out group, then the neurodevelopmental group, again, I'll probably be able to facilitate a change, but they won't be able to reproduce it. So the group I'm talking about with this elbow flexion, they're because you can't do anything else, because they are so definitely grabbing on. But what I would argue is, if you can't see it, it doesn't matter, because what the evidence is saying to us is they need to engage their cuff and then recruit it effectively through range. There are two aspects. One, if you make it more dynamic and incorporate the kinetic chain, it will be easier for them to do that. But also, just by using those basic things, and back to what you were saying about symptom modification, the reality is, if it changes it, it is positive, because you have changed sensory input and you've accessed a different pattern of recruitment. So, and interestingly, to back up what you were saying, we went for years saying, oh yes, it's this muscle or that muscle, and then Angie did her EMG study that showed there was very little correlation between what the clinician found and what the EMG said. But again, what I would argue is it doesn't really matter which muscle's pulling it out, because fundamentally the cuff's got to switch on and then the right bit's got to work through range. So really what you need to know is what should be working when, and trying to facilitate that. Absolutely,
which is incredibly individual. And therefore that's why this subgrouping is helpful to a point, but then there is that expertise we can certainly say.
Yeah.
If we were to take it a slightly different way and say, what are the key differences in how shoulder instability should be treated after the first episode compared to those with multiple recurrences of, say, a subluxation or a dislocating event?
So again, it's very dependent on the history. So if I've got somebody who's got a traumatic first-time dislocation, there are lots of different factors to consider. And I have no doubt I'm biased because of the surgeons that I work with. But I think the evidence is fairly unequivocal that if you have somebody with a first-time dislocation with persistent apprehension and clinical signs of instability, The reality is they've got up to a 95% chance of redislocating if they're involved in sport or overhead activity. But if they're under 22 and they're not sporting, they've still got up to a 72% chance. So that's pretty high.
One of the things I forgot to get some clarity on is you mentioned the window of age, really, in terms of it being prominent. Where are those boundaries for you? Obviously, I'm sure they're loose boundaries, but where do you see as being the evidence saying there's this window in which instability is most prominent?
I think the commonest groups that we see are the adolescents and then the under 30s. I think once you get above 30, the things like your cuff start to complain more.
If it's going to happen, it'd have happened already, right?
Well, we always joke with the evidence because there seems to be this crossover at 40 where everything stops being labral and starts being the cuff. And it's like, well, then if they're 40, what's it likely to be? I have no idea. It depends how physiologically they've looked after themselves. But I think there is no doubt this is inherently a younger population. I can hear Prof now saying to me, this is Simon Frostick saying, but Jo, instability people get older. They do, but if you look at the natural history of something like the polar type 2 group, there's some great papers from Japan that show that actually they get stiffer over time, and so actually their symptoms get less prevalent. I think there's an association with activity modification as well, but in terms of the group I see, it's generally under 30.
Yeah. No, brilliant. Sorry to have interrupted
not at all.
there, but yeah, let's go back to that traumatic first-time dislocator. Persistent apprehension as of when? So, at the time, a week after, are we trying something for a month or so? How long are we judging that?
So again, there's lots of evidence that you could sort of extrapolate to support what you want to say. But as it is at the moment, there's a couple of authors that have tried to look at the significance of the apprehension test remaining positive at, say, 6 weeks. And the reality is what we're realising is it isn't that simple. All right, because some patients, it's a bit like what we were saying before, is that you have a patient who will have a traumatic dislocation, have his surgery, do brilliantly. Another one who'll have surgery and not do well at all, even though every scan shows the structure's intact. And what we know now is that, if you like, that apprehension moves into those emotive networks. So it's driven by something that isn't peripheral and isn't structural. So, the individual patient is a massive consideration. I guess my justification would come at it slightly differently, because for me it's the considerations of what harm are we potentially doing by not operating, because there's no doubt that the more time somebody dislocates, the more structural damage is done, the bigger the risk of degenerative changes if you follow them up over time. But I think the other thing, and sorry to keep banging on about it, I'm obsessed with fMRI at the moment, but the other thing that we now know, again, is that if patients have more than one dislocation, they actually start to get central changes that impact their muscle recruitment. So both in terms of cortical inhibition and excitation, but also just in terms of representation. So for me, if you have somebody who is going back to sport, and this is the under 22 male, who wants to get back to sport or some repetitive overhead activity, who is clearly unstable in the position that he dislocated, and wants surgery, I'm never going to push anybody who doesn't want surgery,
for sure.
Clearly. But if they have clinical signs of instability, a scan that matches those findings, the reality is the longer we leave it, the more they dislocate, the worse their chance of getting a good outcome in the long term. So those are, for me, the factors you have to consider. And there is no, for example, with the Premiership footballers, they'll be operated on very quickly, because actually now we're getting them back at 7.5 weeks, 8 weeks after surgery. So actually the time is very little difference than without doing surgery, which is on average 4 to 6 weeks. Now, in terms of what you said about apprehensive, interestingly, it's not predictive. The evidence doesn't support that. Okay. But all those other factors combined do.
So we, just to take a little side part of that, does that mean we're scanning every traumatic under 25, for example, that's dislocated?
No, because again, it's very dependent on their clinical presentation. I mean, there is no doubt I've seen patients with 270-degree labral tears, and the only thing they can't do is hold on an overhead bar for more than 20 seconds, and they're a bit distressed about that. But it's like, actually, your system's working quite well. Okay. So it's absolutely based on their clinical presentation. If they're an elite athlete, the problem is they will get scanned because they can, and that's a whole other ethical dilemma.
And me and Ian Horsley fleshed around that a little bit, because it is a very tricky one. We're talking a lot about rugby then. Shall I then, just because as if the question wasn't awkward enough already, but my concern is that after, say, a few days post event, there is, from what I've seen, and feel free to disagree with that, of course, that they are apprehensive. Most are apprehensive in that position, and therefore they're going to give a positive test there. So as far as imaging requisition justification goes, you're going to tick enough boxes to actually get that done. So quite rightly, you're saying, no, you wouldn't scan them blanket. But if we were to go down the route of they've had a traumatic event, they're of an age in which we know that surgery might be a priority, they're apprehensive because of the nature of time, as well as the fact that it's been a traumatic event in that position. Mm-hmm. So again, it's that timing issue as to if to scan, when to scan, I suppose.
Absolutely. I think in our unit, because generally patients get referred fairly quickly because the GPs know the pathway, the reality is that if they are in that young age group and their functional demands are high, then it is not uncommon for us to scan them, but on the proviso that they're going to have prehab. And it's very much sold to them that the reality is, we know, we give the whole spiel about the correlation between, scanning and symptoms and how the decision is made. So they're very much bought in that they've got a chance to get better and not have to go that surgical route. Clearly, patients look at the internet and they have their own understanding of what they think should happen, and that clearly will influence the outcome, because that belief is massively important. But generally, the scanning is purely that if they don't then get better with a 6 to 12 week period of rehab. So the key is that at 6 weeks they're improving. If there's no improvement at 6 weeks, then because we know that all those changes then start to happen, arguably we would operate.
Yeah. Okay, and operate fairly swiftly, I imagine, under your pathways.
Yeah, we're very lucky, yeah.
Okay, fantastic. And although I know you're not holding the scalpel, but what would the surgery of choice be in that circumstance?
An arthroscopic repair, unless they had a significant bony lesion, in which case they might choose to do something like a Latarjet. But as a first line, generally it will be a soft tissue stabilisation. Now,
in a, I know it's a really strange way of putting it, but when there's an adverse muscle patterning going on and we feel like that's a neurologically driven sort of adverse firing, shall we say, but we can't set a defib to the area and press the reset button. So what does rehab look like in those circumstances?
So again, it's very much gauged as to whether and obviously I'm oversimplifying this, because
no,
there are so many different things I might do to find a way in. But generally, either I'll find my symptom modification or my improvement. I like to call them improvement tests. So what can I do that improves how they move? Mm-hmm. That will guide my exercise selection. If I can't do that, then it will be, have they got positive 2-point discrimination, left-right judgment, in which case that's where their rehab will start. Yeah. And then I have another group that I guess I would call the neurodevelopmental, which is often that hypermobility group. And with them, I do much more automatic movement. So I might get them doing rolling, catching a ball or something. And they're like, well, I can't do that because I can't lift my arm up. But what's fascinating is if you use vision as their trigger. So if you say to them, I'm going to roll the ball hard and fast and I want you to catch it, and they use their head turn with vision as their initiation of movement, it is fascinating how after very few repetitions actually they've got full movement without dislocation. And I guess because you're tapping into central pattern generators and you're overriding what's become their compensatory pattern.
And it's that rewiring that I was sort of wondering, is that do you like to use those innate movements and upper limb weight bearing is something I think I've spoken to Jeremy Lewis about before in other in terms of tendinopathy loading as well, but it's particularly helpful when it comes to instability, I understand.
It is, and I think what's key about what you're saying, and I guess something I feel quite passionate about, and I have no doubt there are other ways of doing it, and and equally I have no problems accepting that there are loads of different ways to skin a cat, but this works for me because I think it makes sense on what I understand. A lot of what we do is very dynamic. So we use the lower quadrant to initiate the movement, or we'll use trunk rotation to initiate the movement rather than actually making it about the shoulder. So yes, we'd use weight bearing movement, but it would be moving the trunk around the arm or very much so that we're not, because we already know they can't isolate the cuff, we already know they can't activate that local system. So what we want to do is make it as easy for them. So I used a term a lecturer was doing recently, which I'm not quite sure where it came from, but just talked about brain-rich rehab, and it be really saying these patients have got a massive proprioceptive deficit, so let's give them all the sensory input we can, whether that's visual, whether it's tactile, whatever. But the reality is, we know from the motor learning research, and we know from a lot of work looking at dynamic patterns rather than isolated muscle recruitment, you will get more light up of that cortex. So if we're trying to influence those muscle patterns, my belief and interpretation of what's out there, and if you look at Bruckner and Kahn's model, is that you have to get that motor re-education activation switched on in the right way, then your potential for strengthening and endurance is far greater.
But if you jump that gun, then you're just going to be adding to an adverse pattern.
You will fail at some point.
Absolutely. No, it makes sense. Now, in terms of, I suppose it's led on to this next question, and what might be our final one, is if we are wanting to flood the system with feedback, and I suppose that's the wrong way of putting it, because that sounds awfully clumsy, but you've made a good point there, is to try and use lots of different sensations to try and give as much as we can to symptom modify. What other adjunctive methods might that involve? So tactile sensations in terms of manual therapy. Traditionally, we'd consider manual therapy on wiggling stiff bits, but obviously people mobilising unstable shoulders isn't necessarily a tempting one, is it? No. But then equally, the feedback that can be given and the reassurance of touch around an area such as that. And also, a lot of us would put our hands in certain places when we were maybe doing an apprehension test, and there's reason maybe why we do that. It may be sometimes more for us than it is for the patient, but taping's another one that's often used around that area, especially having worked in rugby. It's something that there's people patched up left, right and centre. We're mechanically holding them in, unlikely in a 20-stone rugby player, but is it something that you find useful yourself clinically, but also what does the research tell us about that?
So in terms of taping, probably that's a good place for me to start. Both in terms of manual therapy, taping, whatever, I'm under no illusions that we're just changing something about peripheral input, and I'll talk a bit more about manual therapy in a minute. But in taping, there's actually a couple of interesting papers that have come out this year, one by Kim, and methodologically they're not the most robust, but they give us some interesting information. And Kim's very much looked at, if you did a humeral head compression tape, you improved external rotation strength. Great. Again, I would agree there's no biomechanical or sort of robust effect of keeping something in place. However, there's another paper, and I'm sorry, the author escapes me at the moment, but that again was a relatively small number of normal healthy participants, which is always slightly disappointing. But again, they did more of a kinesio tape effect and showed that they actually improved joint position sense. So that's what I'm interested in, because the reality is, if I use tape, it is to give the patient a better awareness of the joint, or something that helps tune them into what I think they need to correct. So I completely confess I've never done a kinesiology tape course. I just like the idea of it because it's stretchy, and to me, from a peripheral input point of view, it makes a lot more sense than some inert zinc oxide. Uh-huh. But interestingly, there are a couple
Not to say that kinesio tape's not inert. That's quite worrying, isn't it?
I couldn't possibly comment. I think I might can we just cut that bit, Jack? Because I think I'm going to get into deep water now.
Yeah, good one.
But I think the other thing for me that's really interesting, there's a couple of case reports and some small case series that are only in the grey literature at the moment, but that show that, by using compression garments and tubia grip and stuff, improve joint position sense and accuracy in patients with instability. So really, to me, it's another adjunct. It's never a solution or an instead of, but if it's something that allows that patient to do what I need them to do confidently, then absolutely in the initial stages of my treatment, it's a tool. But what it mustn't become is a crutch. So it's very much sold to them, this is to just help you get the feeling of it. As soon as you've got it, you don't need that anymore. In terms of manual therapy, I didn't do all those MACP weekends for no reason. And actually the biggest thing I gained from that was how to clinically reason, which is ironically with what we're talking about tonight, 2 fantastic mentors that just changed how I thought and have probably been the most influential in my career because they changed how I thought and how I reasoned information. But essentially, in terms of, for me, a common issue is the thorax. And I think there's an awful lot written about stiff thoraxes and we manipulate the heck out of it. The reality is, for me, it's rarely stiff. It's usually about muscle recruitment, and it's the commonest place that people compensate when they're trying to protect their shoulders. So there is no doubt that I quite often do some sort of touchy-feely magic to the thorax, and that what I do will vary according to the patient. I think my touch is a communication tool. It's another way in. It's another opportunity to give the patient space to tell me more of their story if there's more to say. If you look at the neurological physios and central key points, it's a very powerful area to input for lots of different neurological reasons. But fundamentally, what it allows me to do is give them an exercise to improve their thorax stability, because thorax rotation is a massive part of upper limb function. And I see phenomenal effects from targeting the thorax on glenohumeral stability. Do I think I'm working magic? No, I think I'm changing a central input that allows them to move differently. Or maybe I just give them a way of finding how to move better. But it is always an adjunct, never an instead of. And I absolutely see anything I do hands-on as a way to facilitate. Is there any evidence? I think there is some nice evidence that supports if you mobilise the thorax, you change recruitment of the scapular muscles. That's got to be good. Is it short term? Absolutely. That doesn't matter. I only need it to be short term to then be able to give them the exercises I need to do to change the way that they're moving and make that system stable.
And the feedback that gives them as a positive reinforcement, and that sits well with all neurological literature, is that let's give them a positive experience that they can then take away. And as long as you're not the one attributing it to magic hands, then it can only be a win, can't it? No, that makes sense. The question we always end with, and it's with good reason, is there any way you would like to direct listeners, any name drops or plugs or anything else you've got coming up at the moment that you want to share?
Yeah, I think it's quite difficult to sort of narrow down who've been the biggest influences. I alluded to my mentors when I did my placement, which is Fiona Creedon, my business partner, and Janet Wiggins, who just were phenomenal in changing how I think. Unfortunately, they're not running courses now, so I'm afraid you've missed the boat on that score, but maybe I could persuade them out of retirement.
They live on in you, right?
Yeah, absolutely. So selling the message. I think in terms of my approach to treatment around being very dynamic in the kinetic chain, I would have to mention sort of Ben Kibler and Tim Ewell, because they had a big influence on me when I spent time out in Kentucky. And for a similar reason, Jo Elphinston, because I get on with Jo great and we have some fantastic discussions, but her courses really helped me formulate in my head why I was doing what I was doing. Jeremy, you can't mention shoulders without Jeremy, and in terms of giving you a really good structured evidence-based approach to shoulders. But I think in terms of instability per se, obviously Andrew and the Stanmore group have made a massive contribution, some lovely papers that they've done that give a nice overview. But also Lynn Watson, who's an Australian physio, has just published her PhD. And again, I was lucky to meet her early on in my career. And again, I think she illustrates this dilemma between a more local muscle-specific approach, which has been part of her PhD, as opposed to what I'm talking about, the brain. And I think by looking at those different people, it gives you quite a good spread of where thinking is at, that very local approach versus that more global brain-directed approach, for want of a better description. And if you want to get it from the horse's mouth, Ian Bailey does a lovely little thing on YouTube, on Shoulder Doc, actually describing his classification system and the reason for it. So that would be it. I'm not very good at plugging myself, but I get shot by Wellbeing if I don't say that I run courses for them intermittently, because I tend to get asked to do things just directly with other people. But I do courses looking at instability and just general rehab of the shoulder and stuff, which are fun and make me keep up to date.
Fantastic. Well, we'll be sharing links to those, of course, and a lot of the literature, or as much as literature as we can scramble together, the stuff we've already discussed. So thank you so much for your time today. It's been brilliant and hugely insightful. I'm sure the listeners are going to love it, but hopefully inevitably I feel we'll be able to chat around other shouldery bits in the future. So thanks again.
Well, thanks for asking me. It's been good fun.
Lovely.
And that was session 20. Brilliant discussion on and off the microphone. And if you guys are unfortunate enough to be anything like me, you'll be wanting to call every other shoulder instability patient you've ever seen to apologise. So many thanks to Jo for enlightening us all. I cringe at how much we ask of you after each episode, so I'll keep this one simple. Please find 5 minutes of your time to complete and share our feedback survey, which you can all find on our social media, and of course on choosehealth.co.uk. As I mentioned in the intro, Heather Watson of our hugely popular Session 15 is offering 20% discount to podcast listeners for a new course, which is a one-day workshop adding value to the integral message that health and work should be intertwined. Heather made a compelling case in Session 15 to argue that returning someone to work or keeping someone in work is as valuable an intervention as any for preventing symptom chronicity and personal distress. Use the code HWM20%, as in the percent sign, at healthworkmatters.com for 20% off, and I will personally give a further 30% off to a listener who is willing to review the course as an undercover agent for Physio Matters. Keep an eye on Twitter and Facebook for more details. And it's ta-ra from me till next month.
So you've been listening to the Physio Matters podcast, discussing Physio Matters because physio matters.